been somebody. She's also done her master's in public health from Johns Hopkins, the US, and has worked in public health and clinical research at the Institute of Management, Ahmedabad, as well as Johns Hopkins Medical Institutes for over 2 decades. So thank you very much, Dr. Purvi, for joining us. And we look forward to you sharing your insights to us, bringing both perspectives to this important webinar, which creates the fulcrum point for the rest of the topics over the next couple of weeks. Dr. Purvi Patel, any thoughts from yours before I switch over? Thank you very much. I will introduce our next speaker also, Dr. Harjot Kaur, who's a district epidemiologist from Amritsar. And I think what she will be bringing to the topics is where I've always put across as being where the rubber hits the road, so to speak. So she will be bringing us into this aspect. And Dr. Karthik Chadar, who's a senior resident in the Department of Community Medicine at VMMC Safdarjung Hospital. He's completed his MD and has also been on the field serving the rural areas for many years, and will also bring in this perspective of influence of looking at insights which are influenced by the field level operations. We have also with us Dr. Vanya Gupta, who is a postgraduate in the Department of Pharmacology in BPS Government Medical College. And I'm sure as government medical institutions go, the pressures in terms of not only having activities happen, but also focusing on where the policies are made and where research on ground comes through. So thank you very much for joining us. And I'm sure you bring us insights to the topic as a whole and as we bring things together. Thank you so much for joining.
Thank you so much, sir, for having me.
It's always a pleasure. It's always a pleasure to hear from people on the ground. So, friends, and in public health, one thing I'd just like to bring things together before we begin the topics. And the first is to keep in mind that this is the second, I think, in the terms of the overall talks on the webinar. But what's also important for you to understand is from the first one, where you're focused on the signs and symptoms of the topic, but mainly now what you're going to be looking at is from a different perspective of prevention and control, which is under the umbrella of preparedness. So the overall umbrella is preparedness, what we are focusing upon, but looking a little bit more details into prevention as well as in control. It'll be a build up to the further detailed discussions in your June sessions that you come out. And I believe that this today's webinar will be the sort of point of expansion of your knowledge into understanding the topic further. So without further ado, I'll now request Dr. Purvi Patel to please begin. I'm sure the audience is very really wanting to hear more from you than from me. Over to you.
Thank you very much, Dr. Machado and Dr. And I think we are India. Sometimes difficult. Yeah, can you see my slides properly?
Yes, over to you.
Okay, okay, thank you. So we'll talk about purposes of implementation and preparedness. So you are aware that global warming is because of greenhouse gas emissions.
My apologies, Dr.
And there is a direct correlation and
sorry.
Yeah.
I think we're having a little bit of a break in the audio. If you could kindly just.
Okay. Yeah, I switch off my camera. I think probably better.
Yes, better.
Now?
Please, back to you.
Yes. Okay. So in the recent years, there is you can see my presentation. Okay, I can see my presentation on the screen now. Yeah. So in the last 2 years, there has been acceleration of temperature increase, and we have gone 5 degrees states, whether it is Uttar Pradesh or Lakshadweep or Dadra Nagar Haveli, have seen the in temperature
I think Gursimran, if you can just check, do we have an
Yes,
audio?
yes. I will check with my
Yeah, yeah. Thank you. Apologies, colleagues, for this technical interruption. We'll just try to get things in order. Over.
Hi. Should I continue now? I think I got
Yeah.
disconnected.
Yes, yes, please. Over to you.
Yeah, I think I'm experiencing bad connection here. So, so all the states have experienced the temperature shift. That is more important. So we don't only expect that only plain regions are experiencing, but also hilly and coastal region. In terms of preparedness, that makes sense that they also be actually be vigilant about having heat stroke or heat exhaustion cases in these regions and prepared accordingly. This is the latest report from Lancet, and it shows the impact of heat in terms of heat-related mortality by mid-century. And you can clearly see the impact in India because of the aging population. Where, the mortality expected with the 2-degree increase scenario is around 1.2 lakh deaths. And for 2-degree scenario, it can be up to 2.5 lakhs. Because of aging population, the impact will be more on more than 65 years old. So we can see the impact that it might have in our population. Now we are aware of all the health impacts, various health impacts, but it also practically important to understand because it has implications. So when we talk about heat, there are two different aspects. There are direct impact, which is heat stroke, heat exhaustion, and all the heat-related illnesses. But indirectly, it also affects other pre-existing condition, especially cardiovascular system. So most of the patients who come with the for the seeking medical care or emergency are with the cardiovascular diseases. So CVD is the number one cause of morbidity and mortality in terms of exposure to heat. So we have to remember that we are just not focused on heat-related illnesses, but also strengthen capacity to handle other kind of illnesses that exaggerate because of exposure to heat, especially cardiovascular, respiratory, kidney disease, and other things are also important to know. Now, in terms of exposure, it's not just heat. We understand the high temperature, but sometimes it is also important that if the lower temperature, the minimum temperatures are also high at night time, we fail to cool down. Humidity also plays a role, and our construction built up by urban heat island plays a role. Now, there are physiological vulnerability that we are all aware of, and socioeconomic factors add into those vulnerabilities because people's access to water, healthcare, electricity, all that matters for how their body reacts to extreme heat. Now, in terms of measures to strengthen health sector response, there are some things that we have identified. First is to have governance structure, to have systemic response and proper implementation, and then monitoring, evaluation, and all those things. We should have strengthening of health sector preparedness. strengthening of surveillance, enhancing technical capacity of healthcare workforce, and community awareness. These are the important aspects identified to respond under National Program on Climate Change and Human Health, from which I'm working from. So the vision of the program is to reduce morbidity, mortality, injuries, and health vulnerability due to climate variability and extreme weather events, including heat wave. This program runs under Ministry of Health, and it actually governs the multiple aspects that I earlier mentioned through having an organizational framework. So at the central level, we are at NCDC, and state level, we have state nodal officers identified for the program. To support them, there is a governing body and multi-sectoral task force. Same as district level, we have district nodal officer in all the districts and multi-sectoral task force. Now you see here, there is a multi-sectoral task force that itself highlights the need for sectoral coordination to respond to some of the climate-related challenges, including heat. As we know that usually the medical profession deals with health outcomes and sometimes also exposure. So when we talk about COVID, we try to control exposure by having mask or other measures. But in terms of climate change challenges, there is no control on exposure by health department. So we need help from other department like transport, electricity. They should come on board to respond to these challenges together to reduce the health impact. So that is why the provision of task force is important. Now in the program, we have multiple area identified, and heat is one of them. So I'll go to heat preparedness, specifically facility and ambulance preparedness. Every year we have now the trend that Secretary Health from Ministry will guide and direct states to take certain steps. It's an annual process because it's a seasonal problem. Every February we have certain updates that are shared with the state to follow them, to prepare them, and to respond them accordingly. Along with the directives, there are advisories that are shared. The advisories include training of doctors and rapid assessment of heat stroke cases and sharing of standard protocols. We have multiple guidelines in this effect, which are shared with the state and available online, which can be utilized. These letters also include ensuring availability of sufficient drinking water and general cooling appliances for all the health facilities, ensuring availability of heat stroke management units with the emergency cooling measures for heat stroke and heat exhaustion patients. Equipment ambulances also with the cooling equipment like ice packs, cold water, body bags, or provide TACO method in the field so that the severe heat related emergencies can be tackled on site. Cooling appliances in the facilities should be ensured. Fire safety should be ensured. Some of the mass gathering events should also be, should also include health aspect, especially heat health aspect into their arrangements so that people are adequately informed, risk is communicated, water and cooling facilities are ensured. Apart from that, long-term measures that are for strengthening the health facilities in terms of energy efficiency, proper cooling, ventilation. For that, we also have guidelines on green and climate resilient health facilities that help them independently work apart from gridded electricity and gridded water supply. So that is also important when we experience multiple or often extreme weather events. The facility should be unable to function independently of energy and water requirements. So some of that aspects are also covered. Now we talk about heat stroke management units. This is the thing that we initiated last year, where we started guiding the states, giving them funding to procure certain equipments to have heat stroke management units. The aim is to early diagnose rapid treatment of severe heat-related illnesses like heat stroke and heat exhaustion, because these are the most fatal illnesses. So what we have advised is for secondary level hospitals, like district hospital and sub-district hospital, they should have dedicated beds in a cool area of the facility, 2 beds for community health center, and up to 5 beds minimum for DH and SDH. Rapid cooling equipments and methods should be available. Methods should be learned by the health professional, and ensuring general cooling and cold water. Primary level, although they might not have bed allotted, they should at least be able to provide primary simple measures of cooling and ORS corners. An ambulance should have rapid on-site cooling facilities. The principle here we follow is a cool first, transport second, because as we know, heat stroke is one of the 3 emergencies that require very immediate, within 30 minutes response to actually save the patient. So fast cooling is the most important thing to save the patient rather than attending other things. Cooling takes care of many things like blood pressure and thermoregulation, so that should be applied first. This preparedness is strengthened by early warning dissemination to health departments and facilities, so they know that heat wave is upon them. Guidelines and trainings are also done every year, and assessment feedbacks are also collected from them. On the right side, you see the portable bathtubs that are set up in the RML for cool water immersion, and heat stroke units are also made in the big hospital that you can see in Ahmedabad. And these are there are guidelines for this. You can always refer to that for more information. Okay, so quickly I'm just showing what are the methods. Leftmost is the most impactful method is ice or cold water immersion that reduces the patient temperature very, very fast within 10 minutes or 15 minutes. So this is the most effective one. The middle one is more sort of a jugaad kind of method, but it works especially in the field. So this is a tarpaulin, and you have to procure ice or cold water, and you can cool the patient in the field faster. And the last one on the right side is a combined cooling method in the low resource setting. If you have a fan and ice box or cold towel, spray bottle, that can help you cool the patient faster. These are two guidelines that again I mentioned. They are also available on NCDC's website that can help you for logistics and methods of this cooling thing. Very important to understand the effectiveness of cooling. So when you try to procure certain things, this is the chart you should be remembering. So you see the highest power of cooling is with the ice and water immersion. You see on the top of that is the best method. That is why portable bathtubs like porcelain portable or even the plastic bathtub or swimming pools are usually useful for the big hospital to procure and cool down the patient. And temperature of the water or ice is also important. As you see on the left side, if you if the increased temperature of the you have, the longer it takes to cool down. You also see the ice packs are okay to use. Ice sheet and ice towels are not that effective, but still works. Fanning, passive cooling, they are all not effective. You see, they're down the line, they are less than the best method or less than the effective method. Evaporative cooling, like spraying, just not doing anything, just keeping the fan or AC doesn't help. So many times we talk about cooling, people think we talk about ACs, but that's not the point. ACs are the passive cooling, and then they do not cool heat stroke patients. So make sure that active activity cooling is required. That is more important in heat stroke cases. Now, once we talk about preparedness, measuring the cases is also important. So we have a national heat-related illness and death surveillance where we try to capture the fatal, this is heat stroke cases. There is always a the balance that we have to maintain between collecting the data and burdening a health system to collect the data and using it. That is why we only include for now heat stroke as our indicator in the surveillance. So what is the purpose? If you report daily, so the system collects daily data, and if you report daily, on daily basis, you will know what is the impact of heat wave or extreme heat on your population. That is like near real-time understanding of what is happening in your area for better response. If you have good enough data for 5 to 6 years, you can actually utilize for planning of action plans, like state or district action plans that we are doing. And if you have long enough data, like 10 years, you should be able to see the impact of climate action on decreasing number of heat-related mortality and morbidity. So this is the purpose. This is a different surveillance system from communicable disease surveillance, and there are multiple challenges because heat itself is a very different disease compared to communicable diseases. So what we capture is suspected heat stroke case, suspected heat stroke death, and confirmed heat stroke death, and some other indicators which are routine indicators that will help us understand excess hospitalization and excess death. So we have divided two different indicators, and the data is collected differently for those. For suspected heat stroke cases, we collect line list of the patients, and for indirect indicators, we only collect aggregate data. And you will find the information on the National Action Plan. It is on the online system. So now, if you're a health facility and you are not reporting, you should report, and you can contact your state health department to enroll into IHIP portal and report it. Otherwise, it is a entry that requires T-form level access ID, and you can report the cases. And when you report, these are the flow of data. Usually, case comes first, and it converts into death if that happens, and its confirmation of death is required. So there are large proportion of cases. Some of them are deaths, and some of them are confirmed stroke deaths. So that is how we capture this indicator for heat impact. These are the case definitions that are purely clinical case definitions, because we know that this is a diagnosis of exclusion. And when you try to do exclusion by lab methodology or any other scanning or X-ray or other things, it takes time. So for avoiding the time consumption for reporting of death cases and deaths, we are taking suspected heat stroke case, which is purely clinical diagnosis. And three indicators are required for that: is a mental status derangement, core body temperature of more than 40, and if you don't have that, then hot and dry skin with delayed vitals, and not having other stroke, infection, or sign of medical overdose. So this is the basic definition that we are utilizing for daily reporting, and based on that, other things follow. Confirmation of heat stroke death is very important, because many times we don't know exact cause. Clinically, we accept, as a public health people, we accept clinical diagnosis of death. We do not require post-mortem. We do not require, verbal autopsy if you have clinical judgment and it says that it is a heat stroke death. We also have a checklist to facilitate medical professionals to identify heat stroke death. I'll show you that next. But this is the form on portal, and as I said, it collects some demographic information, line list for cases, and some aggregate information. So I'm just keeping in interest of time. You will find a lot of training sessions for this on YouTube, and you can refer to that for that. Again, the system is daily reporting. PSC and above facility should report. It is a year-round reporting, and nil reporting required. State and district can monitor this and take actions accordingly. This is a good resource for clinical setting that medical professional can use based on the scenario of the patient that has come to them, possibly due to heat-related exposure that has occurred, and how to label that. They can identify from the combination of symptoms and environmental criteria and label them accordingly. They can confirm it, or they can keep it in a suspected category. Many times there are questions, and what will I do if the patient is brought dead? For that, I would like to highlight, if there is a patient brought dead, but you know, or you come to know that they have pre-existing conditions, you can put it in a suspected heat stroke death category. And if the patient is brought dead, you don't know any other thing, but you can perceive that they are from vulnerable groups like elderly, homeless, and others, you can keep them in a suspected heat stroke death category if the temperature criteria suffices. So this is the form. Moves so fast. Again, guidelines for more information. Private hospitals needs to increase reporting. Yeah, right now we don't have much of participation, except in Tamil Nadu, they have very good system to enroll private hospitals, and they do report in the system. I think these are the green resilient facilities. I'll skip that in interest of time, but yeah, that's it. Thank you.
Thank you very much, Dr. Purvi, for this extremely detailed, and as I probably rightly put it across, you began with the international perspective, but also took us straight down to the national viewpoint. I think it's very important for us in public health to also keep in mind that, understanding the policy guidelines and how important it is, that in terms it gives the framework for us to take it forward, the cascading approach from both the national as well as from the state level. I will not get into many of the details of what you've gone. I think there are some very important points. I request all attending here today, and probably when I'm winding up at the end, we'll be able to stitch things together and probably focus on a few of the important takeaway points that Dr. Purvi has shared with us. So without further ado, I'll request our next speaker, Dr. Harjot Kaur, if you can kindly share your presentation and take us to the next topic.
Thank you so much, sir. Good afternoon, everyone. I'm going to share my screen now. So, is my screen visible?
Yes, Dr. Harjot, you can please put it onto full screen mode. Over.
Okay, thank you, sir. Is it fine now?
Yes, perfect. Over to you. Thank you.
So, good afternoon, everybody. So, I am now starting with a briefing about what practically we are doing at district level, what activities are being done under this program, that is National Program for Climate Change and Human Health at district level. So, I am posted as district epidemiologist in district Amritsar, which is situated in Punjab. So in this program, currently, what activities are being done? So along with the supervision of whole program, what I am doing, I have ensured my facilities, all health facilities which are in Amritsar, are prepared according to the heat wave preparations. So what all have been done under facility preparedness, that I will be sharing in upcoming slides. Next thing which we are doing IC activities at block level to educate the masses, to educate the patients, to educate the staff about the heat wave preparedness and what all they have to do. Third thing which are doing HRI reporting, that is heat related illness reporting on IHFP portal. This portal is an integrated health information platform which gathers all the data regarding all the programs. So next thing which we are doing are we are preparing the annual action plan which is being shared with the state. What all activities which we are planning to do are being collectively shared under this plan. Next thing which we are doing, we are strengthening the manpower, that is we are training the manpower involved in this program, and also we are conducting meetings at district level with district administration and other stakeholders. So first of all, most important thing of all, that is facility preparedness, how we have prepared our health facilities which are in our district Amritsar, that I'll be briefing you all. So, firstly, we have prepared heat stroke wards in all the health facilities till PHC level, that is in district hospitals, in subdivisional hospitals, in CHCs, and in PHCs. So, in these heat stroke wards, we have sufficient amounts of ice packs, other cooling material. We have cool area where we move the patient whenever we receive a patient with suspected heat stroke or other heat related illnesses. We have IV fluids and all the drugs in sufficient amounts. We have also prepared ORS corners in all our health facilities, which have zinc and ORS and drinking water available every time with us. We also have IC material displayed in our all the health facilities, which have been provided to us from the state headquarters. And also the treatment protocols which have been provided to us from state have been displayed in all the health facilities. Health related advisory which was issued to us from the state have been circulated to all the health facilities, to all the senior medical officers, and do's and don'ts which we received from the state have been conveyed further. So I'm sharing some of the pictures of heat stroke wards which are present in our health facilities in district Amritsar. So we have separate beds for earmarked beds for these patients, and we have signage proper. uh, these IC material are displayed on the walls, where we have displayed in local language that what are do's and don'ts, what the patients have to do if they suffer from any of these heat related illness, and what they don't have to do. So heat stroke corners have been prepared. Now, these are some of the pictures which I have collectively shared in one slide. These depict ORS corners in all our health facilities. So, we have signage displayed, we have IC material displayed regarding the dehydration and how to hydrate and what ORS does, what are the benefits of ORS, how to make ORS if they don't have ORS, how to make or prepare ORS at home with the available materials. And also, we have prepared ORS available with us every time if a patient or a child comes. So next thing, IC activities. So we continuously do IC activities in all our health facilities on special days also, and routinely also. We educate our patients, also our staff, regarding the heat wave, or the whenever any day special day comes, like no pollution days are celebrated, like environment day was celebrated. So normally we educate the patients about do's and don'ts whenever heat wave, like circulation is there, heat wave condition is there. We educate the patients, like about small things, like they do not have to step outside in extreme heat, they have to carry umbrella, they have to hydrate themselves, they have to carry a bottle of water every time with them. These simple things we educate the patients, and whenever they identify themselves that they are suffering from any type of heat related illness, they immediately have to report to hospital, and they immediately have to hydrate themselves. So we also educate the patients about the harmful effects of stubble burning. Like in this picture, you can see there are posters displayed in our health facilities regarding the harmful effects of stubble burning and beneficial effects if they don't burn the stubble. So last year we inaugurated plantation drive in district Amritsar, and the total target which was given to district Amritsar overall was 50 lakhs, and 25,000 plants were planted in the health facilities of district Amritsar. And we inaugurated these plantation drives involving the local influential leaders. Like in these pictures, we have involved local MLAs in inauguration of the plantation drive. So this was the advisory which we keep on like receiving from states. It clearly depicts the normal body temperatures and what heat wave is, and what are the heat related illnesses, what are the ranges of illnesses. Like not only heat stroke is heat related illness, other types of illnesses can also be there, like heat rash, heat edema, heat cramps, heat tetany, heat syncope. These all are forms of heat related illnesses. So we educate patients about these also. So there are symptoms mentioned about these heat related illnesses, and what are the danger signs of heat stroke and how to identify. We educate the patients about all these signs, that whenever you get to know, whenever you feel like you're suffering from these symptoms, immediately report to hospital and immediately start the cooling measures. So these do's and don'ts, these also have been circulated to all the health facilities in a district Amritsar. So this was the facility preparedness letter which we received from the state, and we circulated in all our health facilities, and we prepared our health facilities according to these protocols. All these protocols have been fulfilled in all our health facilities. So in these pictures, these are just depicting the do's and don'ts have been displayed in all our health facilities. These posters which we received from state, we displayed at all the reception area of all the health facilities, so that patients can read. These all are in local languages, these all in Punjabi, so patients can read and can get to know what are the do's and don'ts in heat wave condition. So we continuously do these activities, like we heat related precautions are being continuously issued in print media from our honorable civil surgeon ma'am, under her name and under her uh, photo. We continuously publish these precautions in the print media, so that patients and normal public can get to know what can be the symptoms of these heat related illnesses and heat wave condition, and how to prevent themselves. So we have published these in English, Hindi, and Punjabi, the languages which are there in the Punjab. So these are some of the pictures that depict the Environmental Day celebrations. So we have covered all these celebrations also in print media, so that public can be made aware that how we can save our environment. So next thing is strengthening manpower. So what we are doing under this is, so I have trained my CHOs, ASHA workers, medical officers, MPHs and MPHWs. I have conducted trainings of all these manpower regarding all these precautions which all we have to observe regarding the heat wave conditions, heat related illnesses. And also I have conducted virtual sessions regarding the implementation of the program, and HRI reporting is one of the important components of this program, so I have conducted trainings regarding that also. So in on the left side you can see a picture, and these data we enter on the portal regarding the total emergency medicine or emergency pediatrics cases, casualty cases. Wherever there's no emergency, there's only OPD. So we are entering OPD data, so that we can detect whenever a case is like diagnosed or suspected heat stroke case is detected. So immediately we come to know that there is a case, and we come in action. So continuous meeting with stakeholders have also been conducted in Amritsar district with the all the concerned departments. So these are some of the photos of these trainings which I conducted in my civil surgeon office. All the staff like CHOs, medical officers, MPHW and MPHs were involved in the trainings, and virtual sessions also I conducted of all the manpower. So these are the meetings conducted with the district administration under the chairmanship of Honorable Deputy Commissioner Sir. All the departments were present, and the issues discussed were like pollution, heat wave, plantation, and other environmental issues. These all are the pictures of the meetings conducted with all the concerned stakeholders. So with this quote, I end my session. I just read this quote yesterday on the internet and liked it very much. I hope you all will like it. So we are the first generation to feel the full effects of climate change and the last generation that can do something about it. So with these words, I thank you all for your patient listening. If any query, you can ask.
Thank you very much, Dr. Harjot Kaur. And I think the last point that you made of we're the first generation to feel the full effects is probably very close to the reality that we are seeing across the world. And depending and looking at India, in which we are on the coastal side, we have communities living, but also all over the place in terms of where this climate change is having its tremendous impacts. Thank you so much for sharing, but all the more importantly, thank you for sharing what's happening on the ground. And I think that's where, for our colleagues listening in, the previous speaker, Dr. Purvi, was talking about things that were at the national level, the framework, the sort of guidelines and documentation that is required. Dr. Harjot is now bringing in what we are seeing is what's possible to be done at the unit of the public health system of the country, and that is at the primary health center. And she, as the epidemiologist on the ground, is the best person to tell us also probably things that don't work. And I'm sure, Dr. Harjo, there's a lot of work that went in for those photographs. Probably we don't realize how much of efforts are taken in terms of developing training opportunities, I would rather say, because the material is available. You have wonderful resources. And thank you, Dr. Purvi, also for sharing those resources, which I believe will be extremely important for our colleagues who are listening in and participating in this. So again, once again, not getting into very many details, but just thank you again for being on the ground. And I think as we should begin to say, thank you for the work that you do. So I will now request our next speaker to kindly take over. That is Dr. Karthik. Welcome and take us through clinical management. Over to you,
Thank
sir.
you, sir. Thank you so much, sir. And I would also like to thank Dr. Jugal Kishore, sir. He has not joined the meeting with us, but for providing this opportunity. So, is my screen visible? I would like to ask.
Not yet. Thank you. Not yet.
Just
Something, I think. I think a wrong screen. Yes, now we can see it. If you can just put it into full screen mode. Yes, we can. Over to you.
Thank you, sir. So, I would be discussing the clinical management and the prevention of heat-related illnesses. And till now, we have seen from Dr. Puri ma'am and Dr. Harjot ma'am how they have outlined the greater aspect or the broader perspective of this issue. And also good to see that there are PHCs that are having this heat-related illnesses as a core point in the management and dedicated spots for that. So I would like to go deeper into the clinical part of it and also some points about the prevention which are being dealt with through the slides, and also how Puri ma'am and Dr. Harjot ma'am have already outlined some of it. So I would like to start with this. So we have now seen that heat illnesses, it is either due to the excessive load or the failure of the thermoregulatory function. So both of these things is what contributes to the development of heat-related illnesses. And some unacclimated individuals, they are more vulnerable to it. And we see the spikes of this mortality, especially during the heat waves, which gives it an epidemiological pattern. And there are obviously the risk factors which have been identified, like age, nutrition, the level of nutrition, the environment where they are, and the level of exertion that is being they've been through. So the high risk population, if we see the high risk population, they generally consist of the elderly, people who have poor thermoregulation, they have comorbidities, they have also other predisposing factors which make them more vulnerable. Then the very young, and they also do not have fully developed thermoregulation, and the adolescents and and teenagers who generally have a risk-taking behavior and do not understand the consequences of their activities, and they may go on playing, or they may go on in some strenuous physical activity even during heat waves. So they are predisposed to such conditions, and individuals suffering from obesity, and some unacclimated individuals, and then there is apart from that, there is also the occupational part of it, where laborers, military people, athletes who are under physical stress, and many a times the prevention part of heat-related illness is sidelined in such occupations. Then apart from the individual risks, there are some environmental risk factors like heat waves and lack of access to cooling systems, malnutrition, social isolation is generally seen There have been reports from the mortuary where people have found some dead body which has been there for some time, and no diagnosis or no forensic investigation would lead them to any functional, any systemic cause, any organic cause, and then they would conclude it to be due to heat exhaustion or heat related illnesses. Then there is occupational exposures, as we have seen in certain occupations, which may predispose them to such conditions. Then apart from that, there are some medication-induced risks like anticholinergics. They decrease the sweating and the cardiovascular response and can impair the and can impair the heat loss function. Then there are some antidepressants which can affect the hypothalamic thermoregulation. Then there are antihypertensives which are taken for hypertension. They decrease the peripheral blood flow, and in turn they also decrease the vasodilation part. So they can eventually predispose people to a higher risk to heat related illnesses. And some stimulants such as amphetamines can increase the heat production in the body as well as the muscle activity. So the taking point from this is that when such medications are being taken, there should be special they should take notice of if they are developing any heat related illnesses, and they should prevent themselves from exposing themselves into such conditions. Then cardiovascular strain can also lead to such conditions where there is decrease in the heat dissipation, there is decrease in the blood volume, and people who have these cardiovascular diseases, they are always at a higher risk, so they have to take these precautions more seriously. So a lot of these diseases, they mimic the heat stroke. So we have to be at the level of health facility, we have to be cautious about labeling diseases which may be something else, and maybe we are labeling them as a heat stroke, or even the reverse is true, where diagnosis of heat related illnesses gets missed because it mimics so many different conditions. So malignant hyperthermia, some neuroleptic malignant syndromes because of antipsychotics and SSRIs, infectious diseases, sepsis, which has hypervolemia, and endocrine disorders like thyrotoxicosis and some toxicologic disease, drug toxicity. They also mimic the conditions of health-related illnesses. So as a medical professional, as a health worker, people should consider all of these diagnoses also before initiating treatment. Then the spectrum. So we come to now the spectrum of the heat-related illnesses, which have been briefly discussed. So we will just discuss them in a little bit detail with the associated preventive measures for each of them. So there are some minor heat-related illnesses, which are heat edema, heat rash, hyperventilation tetany, and heat syncope. And then there are some more serious and major heat-related illnesses, heat cramps and heat exhaustion, and finally heat stroke. So over here, the level of prevention in each one of them differs, and so we will see how each one of them we can see. So starting with the heat edema. So heat edema is because of it's basically the mild swelling in hand, feet, and ankles seen in the dependent areas, and it occurs early during the heat exposure, and it is caused by the vasodilation that is happening in the peripheral vascular system because of the heat stress, and also increase in the release of the ADH, that is antidiuretic hormone, and aldosterone, which causes the water to stay in the body. So it is generally managed with removal of the exposure, and managed with elevation of the legs or the dependent part, and avoiding any diuretics that the patient might be taking. So heat edema generally is in itself a self-limiting condition, and it corrects on itself if appropriate management and simple management techniques are used. So this is one of the milder forms of heat-related illness. So if we move forward, then there is prickly heat, also known as Melia rubra, and it is an itchy rash which is found in the cloth areas. So the simple mechanism is that the person perspires, and because of this diaphoresis and sweating, because of maybe and because of the blockage of the pores. So these pores can get blocked because of sebum, because of dust, because of tight clothing. So anything that blocks all of these pores. So once these pores are blocked, there is no sweat which can evaporate, and once these sweat ducts get blocked, the sweat glands in itself gets inflamed, and then they give rise to these vesicles. So this heat rash also resembles a lot of other dermatological skin conditions. So it is important that a delineation is made between such conditions and other dermatological conditions. So one epidemiological link can be drawn that these conditions are generally seen in times when heat waves are going on. So then the basic treatment involves just use of antihistamine lotions. Chlorhexidine lotions can be used. Keep the areas clean. Salicylic acid can be used, and we have to prevent and it can be prevented by wearing loose and breathable clothing. So tight clothing is not recommended, as well as the skin needs to be cleaned properly, and that the blockage of pores should be avoided. So it is also again a self-limiting condition, does not get complicated in most of the cases and can be easily dealt with. Then we move on to heat syncope, and it is just a sudden collapse of a person who is standing or who is in exertion and has been exposed to heat. And generally the patients are elderly or unacclimated individuals who have and it is due to the decrease in the venous return, and which is in turn a consequence of dehydration and the vasodilation that has been going on because of the heat stress. Heat syncope also recovers with rest and appropriate fluids and cooling. So again, the heat syncope also generally does not proceed into more serious forms once the exposure is removed and appropriate management strategies are adopted. Hypervention tetany is one of the consequences, which is because due to heat induced hyperventilation, and the symptoms are generally paresthesia or carpopedal spasm, and it is treated by reassurance and putting the person in a cool environment and regulating their breathing, and slow breathing technique can be used here. Then we move to the more serious and clinical manifestations of heat-related illness, and one of them is heat cramps. So once a person is in heat, when the person is working in heat, such as laborers and athletes, as we discussed, soldiers, and even people who are, as of now, there are a lot of people who work out regularly. So these people are indulged in sports. So they can develop these painful spasms of different muscle groups. So once this happens, the person experience cramps in the muscle. There can be falls because of the cramps, and this is linked to the sodium potassium depletion. So what happens is, in such individuals, they would be feeling this heat. They would be taking copious amounts of water. So over here, one issue that happens is, because water is hypovolumic fluid, so hypotonic fluid. So this intake of this water in itself results in even a lower level of sodium and potassium in the body. So in these conditions, the treatment generally is to replenish the electrolytes. So treatment is with rest and electrolyte solutions. So ORS can be recommended for people with heat cramps. Then we come to heat exhaustion, where the core temperature is still less than 40.5 degrees Celsius and the CNS function is still preserved. And again, here the main mechanism is the depletion of water and sodium. They can be either ways, either only water or either only sodium, and both can be depleted. The symptoms include headache, nausea, orthostatic hypotension, and treatment is with IV fluids and cooling. Excuse me. So as Dr. Puri also pointed out regarding the management of heat exhaustion, so we see the removal of heat is the primary point where we start. So we have to remove the person from the exposure, excuse me, and start with the IV fluids. And also important is to cool aggressively. So this aggressive cooling is important because when the symptoms start, so once the symptoms are recognized, and if at all any CNS symptom is recognized, CNS symptoms is the person not responding to you, not having a good GCS, person who is if you see any CNS symptoms, you can conduct a simple CNS examination and MMSE, and you can understand. Once that happens, an aggressive cooling strategy has to start. And these patients will most of the times require inpatient care. And we also need to know the different morbidities that they might be having, and those morbidities need to be kept in sight before we manage these patients. So heat stroke in itself can be classified into two types, which is classic heat stroke and also the exhaustional heat stroke. The classic heat stroke is generally seen in the elderly, in the people with chronic illness and who have poor fluid access. And these people you will see them with anhydrosis, that is sweat is absent, and they have hot, dry skin, and CNS dysfunction is present. The biomarkers are raised, the liver biomarkers is raised because hepatocytes are the first cells to get damaged because of heat. So once these hepatocytes get damaged, the serum transaminases, they rise almost 100 folds. Then markers for disseminated intravascular coagulation, that is DIC, there's a rise in those, and hypernatremia is seen. These people will inadvertently require ICU care and close monitoring. We have exertional heat stroke, where it is seen in young and active individuals like athletes and laborers. They will present with profuse sweating. Very rarely, they might present with rhabdomyolysis and renal failure. Over here also, the creatine kinase and LDH are elevated, and we'll see a hyponatremia and hypocalcemic picture. Again, the treatment is with rapid cooling and the resuscitation of fluid. So both of them also have some shared features, like cardio biomarkers will be elevated. So these are important in diagnosis, but the management more or less remains the same. So these are some points. I'll just you can. So pathophysiology is seen, and also in the patients will be required about the airway and pulmonary support. So intubation is often required. So these are always almost taken care at tertiary care level. So the point over here is prompt referral from the primary and secondary units to tertiary care units, where there is a chance of a heat stroke. So the circulatory management is by giving in fluids, and dopamine, dobutamine can be used if the cardiac activity is low. Arrhythmias can also occur in such conditions because of the electrolyte imbalance, and arrhythmia can be managed according to the guidelines, and generally they resolve with cooling. And antiarrhythmics are most of the times avoided over here, and because the pathophysiology is different. Then there can be, for the coagulopathy shivering seizures, the short-acting benzodiazepines can be used. And DIC has to be monitored in all such patients. And if needed, the free frozen plasma and platelets needs to be arranged. This is just a simple visual representation of how heat exhaustion, heat stroke, they differ, and why we need to know at points, because heat stroke almost always requires intensive care. So if we miss those symptoms, then there is a high chance of mortality. Almost 40% is the chance of mortality if not treated. So heat stroke in itself, we need to recognize these symptoms, which will include headache, confusion, then sweating would be absent. Apart from that, the person might have red hot skin, may lose consciousness, and the pulse is rapid and strong. So all the first responders, the the first responders at the site, even at and then at the hospital level, in the emergency services, should be able to distinguish these two conditions distinctly to manage the heat-related illness. Then some points about the prevention part. So at individual level, so I just summed up all the prevention we discussed, that we just discussed, is summed up in this table. So over here you can see the hydration is to drink water regularly. So it's generally said that a man in India might require a man in India who's doing work in heat requires around 1 liter of water per hour, and sedentary would require half of this capacity. So drinking water is prime, and it need not be stressed further how important is this. And but definitely there are some chances where some heat related illness, they might interfere, so that needs to be ruled out. So if there are any cramps with the person is having any cramps, then the water intake should be regulated in that way. And we should also avoid things like alcohol, caffeine, and diuretics, which make people lose more and more water. Then clothing should be lightweight, light colored, loose fitting clothes, use of hats and umbrellas, staying in shaded, air conditioned areas, and using fans and wet clothes to cool down, and avoiding any strenuous activities during peak heat hours, and taking frequent breaks. Monitoring elderly, the children, and chronically ill, and educating the caregivers and the workers about the various harms of um, in exposed heat for long times. And acclimatization, gradually they increase the time spent in the hot environments and train and adapt progressively. There should be provision of cool and rest areas. Antipyretics generally have no role in the heat stroke and should be avoided. And sorry, acetaminophen, that is paracetamol, increases the liver stress. Then some community level interventions, I think they have been discussed early on by Madam in the initial two sessions. And again, I would like to again stress on it that community awareness generation sessions like health talks, role plays, and demonstration, they do play a role in making this a topic which can be talked about even after the health talk is over. The health talk or the role play or the community demonstration should be such that even after they are over, people talk about them and share with their peers and at home, their family members. And community health workers need to be trained in regular manner. All the regular epidemiological surveys, as has been mentioned, they are going on and should be at points should be evaluated and monitored. Installation of rehydration points at key locations. And obviously there are a lot of different sort of myths that might be in the community among the people that needs to be addressed time and again, so that proper management and a comprehensive understanding of heat-related illnesses among the people as well. Then some specific points that I just wanted to mention over here, like regulation of work. So this is something that organizations might need to be more cautious about it, about the duration of exposure of in the hot environment, and how much time a person is spending in such an environment, and assurance of rest in between the intense work periods. And as already pointed out, the clothing should be light, they should be loose and of light colors to reflect as much as heat possible. Protective goggles, shields, and helmets are helpful in such environments where there is an exposure to heat. And the work environment, the temperature and humidity may be controlled through ventilation and air conditioning. So these are some systemic level prevention strategies which require a more effort rather than just individual level effort. So to accomplish all of this, there needs to be appropriate coordination between the different agencies that might be involved in providing all of these prevention services. So that is from me. I would like to thank again Sphere India and Dr. Jugal Kishore sir for giving this opportunity to be able to discuss the clinical management. Thank you.
Thank you very much, Dr. Karthik. And I think basically I put it on this side is that you've probably taken us to the bedside of treatment. Thank you very much for bringing that aspect out, especially from Safdarjung Hospital. As a consequence of just as a consequence of as a con Sorry, my apologies. As a consequence of you seeing the final impact of the heat stroke on the ground, but also taking us through the extreme clinical details and also bringing out the importance of our for the next speaker is on vulnerable populations. You flagged that out well, but also you brought out to us in the importance of understanding all of these in terms of even at autopsies, which is something which probably most of us will not think about. So to our colleagues who are listening in, it's also important for you to see the broad aspects of how something as straightforward and simple as heat stroke will have its implication on so many different other fields, but also on the comorbidities and something which we tend to forget when we're dealing with it. So thank you so much again, Dr. Karthik, for bringing that out, and especially on also the aspect of community perspective awareness. And as you rightly put it, also the wonderful slide on prevention as a whole. So I think there are two slides here which are very important for the takeaway for all our participants today to follow through. So I'll request our next speaker, Dr. Vanya Gupta, over to you. Thank you so much.
Thank you, sir.
Thank you so much, sir. So can you see my slides?
Yes, if you can put it into full screen mode, please. Thank you.
Just a second.
Yeah, it's
visible?
yes,
Yes, yes. Now it's in full screen mode. Please carry on. Thank you.
Okay. Thank you so much. Okay. Okay. Good afternoon, everyone. Thank you so much for having me today as a speaker in this webinar among all the distinguished dignitaries present. We have been discussing this very crucial and increasingly urgent issue of heat waves, already of which I will be focusing on the profound impact of heat waves on the two of India's most vulnerable populations, that's our newborn and our elderly. So, as the climate change accelerates and heat waves are becoming more frequent, more intense, and more prolonged, posing significant health risks and that demand our immediate attention and concerted action. Heat waves in India are no longer an anomaly, they are a very harsh reality. So, climate change is driving these extreme weather events, making them more common and more severe, lasting for longer durations. And within this escalating challenge, certain segments of our population bear a disproportionately higher burden. Newborns and the elderly stand out as particularly susceptible to heat stress. Why? Because their bodies are either still developing or have compromised thermoregulatory systems, making them less capable of adapting to extreme temperatures. Studies have indicated a 20 to 30% increased mortality risk for these groups during periods of intense heat. Throughout this session, we will explore the specific health, socioeconomic, and long term consequences of these heat waves and critically discuss the strategies that we can employ to mitigate their devastating effects. So, first, let's focus on our youngest and the most fragile, the newborns. Their physiological makeup makes them incredibly vulnerable. Unlike adults, newborns have limited thermoregulation capabilities. Their sweat glands are immature, meaning they can't cool themselves effectively through sweating. Furthermore, their higher surface area to body mass ratio means they absorb heat more rapidly from the environment. This combination leads to rapid dehydration. Higher temperatures can cause excessive sweating, which in turn leads to swift fluid loss and an imbalance in the essential electrolytes. Compounding this, their immature kidney function means they cannot efficiently regulate these electrolyte levels, further increasing the risk of serious complications. When a newborn becomes dehydrated, you might observe these symptoms such as weakness, irritability, and in severe cases, seizures, cardiac arrhythmias, and even organ dysfunction. It's a precarious balance that can be easily disrupted by extreme heat. The immediate health impacts on the newborns are severe and require urgent attention. One of the most critical is hypothermia or overheating. When a newborn's body temperature rises dangerously, it can manifest as fever, irritability, lethargy, and rapid breathing. In most severe instances, it can lead to seizures. Beyond overheating, heat waves can exacerbate respiratory problems. The combination of high temperatures, humidity, and often poor air quality places an immense strain on the newborn's immature respiratory system. This can result in labored breathing, wheezing, coughing, and even apnea, that's pauses in breathing. Tragically, heat stress is also defined as a contributing factor to sudden infant death syndrome, SIDS. Less severe but still distressing are the heat rashes, common in infants due to blocked sweat pores, particularly in areas like the diaper region. And finally, gastrointestinal issues, just like diarrheal diseases, become a heightened risk due to dehydration and the potential for contaminated water or food in hot conditions. Impact of heat waves isn't confined to the postnatal period. It extends to pregnancy itself, affecting both the mother and the unborn child. Pregnant women are physiologically more vulnerable to heat stress. Normal changes in their circulation, blood volume, and hormonal sensitivity during pregnancy reduces their body's ability to regulate heat effectively. This maternal vulnerability directly into adverse pregnancy outcomes. We see increased risk of fetal distress, a higher likelihood of neonatal intensive care unit admissions, and concerningly, complications like growth restriction, low birth weight, premature birth, stillbirth, and even congenital birth defects. The underlying mechanism is often physiological, that is, increased air temperatures can divert the blood flow away from the placenta to the mother's skin to facilitate cooling, thereby limiting the crucial oxygen and nutrient supply to the developing fetus. Now, let's turn our attention to the other end of the age spectrum, that's our elderly population. Like newborns, older adults possess distinct physiological vulnerabilities that make them highly susceptible to heat stress. Their ability to sweat is often reduced, and their sensation of thirst can be impaired, meaning they may not realize that they are dehydrated until it's too late. A significant factor is the prevalence of pre-existing health conditions. Many elderly individuals live with chronic diseases such as cardiovascular issues, respiratory ailments, diabetes, and kidney disease. Heat stress places additional strain on these already compromised systems, exacerbating their conditions. Furthermore, many older adults are on medications like diuretics or anticholinergics, which can interfere with the body's natural temperature regulation. Sorry. Or increase the risk of dehydration. Reduced mobility can physically hinder their ability to seek cooler environments or access water, and social isolation can mean they lack immediate assistance or monitoring during a heat wave, making them silently suffer. Their immediate health impacts on the elderly are equally, if not more, dangerous. Heat exhaustion is a very common precursor characterized by heavy sweating, weakness, cold, clammy skin, nausea, vomiting, dizziness, and muscle cramps. If left untreated, this can rapidly escalate to heat stroke, a severe life threatening medical emergency. Heat stroke is marked by a very high body temperature, often above 40 degrees Celsius, and can present with hot, dry skin, though sweating may still occur. There's confusion, disorientation, seizures, and even loss of consciousness. Immediate medical attention is paramount in such cases. Dehydration, as mentioned, is a major concern, potentially leading to kidney failure and dangerous electrolyte imbalances, further worsening existing chronic conditions. The added strain on the heart and kidneys due to the heat stress significantly increases the risk of cardiac events, strokes, and renal complications. Beyond the physical, heat also takes a toll on mental health. High temperatures are linked to increased irritability, anxiety, sleep disturbances, and can unfortunately exacerbate pre existing mental health conditions like depression and PTSD. The consequences of heat waves exposure are not always immediate. They can have lasting effect on both newborns and the elderly. For newborns, repeated or severe heat stress can contribute to chronic respiratory conditions, lead to long-term renal impairment, and even impact neurodevelopment, potentially resulting in cognitive difficulties, irritability, and sleep disturbances as they grow. Their developing immune systems can also be weakened, making them more susceptible to infections. For the elderly, heat wave exposure increases the risk of recurrent heat-related illnesses and can lead to long-term organ damage, particularly affecting the kidneys and the heart. This can result in a significant decline in their overall health and independence. The cumulative stress from extended periods of high day and nighttime temperatures creates a dangerous cycle, increasing the overall risk of illness and mortality across both the vulnerable groups. The impact of heat waves extends beyond individual health, creating a significant socioeconomic burden on families, particularly those with newborns and elderly members. We often hear of heat poverty, where vulnerable families are forced to take on loans to afford cooling solutions like air conditioners, inadvertently deepening their financial struggles. Livelihoods are disrupted, especially for parents and caregivers in outdoor occupations who experience reduced work capacity and lost wages during extreme heat, directly impacting household income. The increased medical expenses for treating heat related illnesses in both newborns and the elderly add another layer of financial strain. Furthermore, Heat waves can worsen droughts, leading to crop failure and threatening access to nutritious food and safe water, which directly impacts child nutrition and overall household well being. And let's not forget the immense stress and exhaustion placed on parents and caregivers who are constantly trying to keep their vulnerable family members safe and cool. Let's look at the current situation in India as of May 2025. The summer has been somewhat unusual so far. Many parts of India have experienced a cooler and wetter period than what is expected typically, with heat wave days largely absent in May due to favorable weather patterns like frequent western disturbances and moisture incursions. However, it is crucial not to become complacent. Despite this current respite, the India Meteorological Department had earlier issued an alert forecasting above normal temperatures across the country from April to June 2025. In fact, February 2025 was recorded as the hottest in 125 years, indicating the broader trend. Sorry. The persistent risk remains significant. Approximately 57% of Indian districts, home to 76% of our population, are still categorized as being high to very high heat risk. This includes major states like Delhi, Maharashtra, Rajasthan, and Uttar Pradesh. So, what can families do to protect their vulnerable members? Prevention and mitigation are the key. First and foremost, stay hydrated. For infants under 6 months, exclusive breastfeeding is crucial, and breastfeeding mothers must ensure they drink plenty of fluids. For children aged 6 months or over, for elderly individuals, regular water intake is essential, and even if they don't feel thirsty, they should do that. Oh, ORS solution and traditional homemade drinks like lemon water or lassi can also be highly beneficial. Secondly, staying indoors during peak heat hours, typically between 12 p.m. to 4 p.m. Dress the newborns and elderly in light colored, loose fitting, breathable cotton clothing. Implement effective cooling measures to use fans to circulate air but not pointed directly at the baby or the elderly. Apply cool, damp clothes or lukewarm baths. Keep curtains and blinds closed during the day to block out the heat and ensure good ventilation in rooms. Crucially, create a safe sleeping environment. For babies, remove excess padding from the cots and use thick cotton sheets. For the elderly, ensure their sleeping areas are cool and well ventilated. And critically, never leave the vulnerable individuals unattended, especially in cars or closed unventilated spaces. This can be fatal. Finally, learn to recognize the symptoms of heat related illnesses such as dry lips, irritability, or fewer wet diapers in babies, or dizziness, weakness, and confusion in the elderly. Seek immediate medical attention for any severe symptoms. Beyond individual and family efforts, the government and community initiatives play a vital role. Heat action plans are being implemented by states in collaboration with the National Disaster Management Authority. These plans provide crucial framework for early warning systems, preparedness, and response, explicitly recognizing infants and the elderly as highly vulnerable groups. The India Meteorological Department is central to early warning systems in issuing seasonal, monthly, and extended range forecasts and alerts through various media, including color coded warnings to indicate the severity of heat. Healthcare preparedness is also being strengthened with dedicated heat wave wards being set up in the hospitals, equipped with cooling facilities, ORS stock, and trained staff to manage heat stroke cases across all age groups. Primary healthcare centers and ambulances are being bolstered for on-site rapid cooling, and the National Heat-Related Illness and Death Surveillance System is collecting real-time data to inform responses. Public awareness campaigns are essential for disseminating health messages and advisories to all vulnerable populations. Recent initiatives such as Delhi's Heat Action Plan for 2025 include establishment of 3,000 water coolers and water ATMs across the city, particularly near the public transport hubs, benefiting all the citizens, including the elderly. The deployment of Jal Doots, that is, trained personnel who distribute purified drinking water, is another proactive step. We are also seeing cool roof pilot projects in urban areas to reflect the heat and reduce indoor temperatures, and the training of students in heat wave preparedness and deployment of Apada Mitras, the disaster response volunteers to assist vulnerable communities, including the elderly in slum areas. Now, let's look at what we need to do for the long term. Effective heat wave management requires a multi pronged approach that goes beyond immediate responses. Firstly, we need climate resilient infrastructure and urban planning. This means mandating cool roofs and green building codes for both new constructions and retrofits, especially in vulnerable communities and public buildings. These technologies reflect sunlight and reduce indoor temperatures. We must also expand the urban green spaces by increasing tree cover, parks, and water bodies in our cities. This is crucial to mitigate the urban heat island effect and provide natural cooling. Improving public cooling centers is another priority. They need to be established and well equipped and widely publicized, particularly in low income neighborhoods where access to private cooling is limited. Finally, promoting sustainable transportation and creating shaded pedestrian pathways can significantly reduce heat exposure for commuters. Secondly, strengthening healthcare systems is paramount. This involves investing in continuous capacity building for all the healthcare professionals, from doctors and nurses to community health workers, ensuring they are well versed in heat related illness diagnosis, management, and prevention across all age groups. We must also fund more research into the long-term health impacts of heat on vulnerable populations and strengthen our surveillance system for heat-related morbidity and mortality to better track and respond to trends. Developing specialized protocols and facilities for managing heat-related complications in newborns and the elderly, including dedicated geriatric and pediatric heat clinics, is essential. And to reach those who are isolated, we should utilize telemedicine and community outreach programs, especially for elderly individuals and families with newborns in remote or undeserved areas. Thirdly, social protection and awareness initiatives are crucial. This includes implementing targeted social support programs that provide financial assistance or direct aid for cooling solutions such as fans or insulation to low income households with vulnerable members. Empowering local communities to develop and disseminate localized heat warnings and provide mutual aid during heat waves can create vital support networks. We need continuous, sustained, and multilingual public education campaigns during diverse media to educate everyone about heat risks, symptoms, and preventive measures, always emphasizing the specific needs for newborns and the elderly. Providing resources and training for caregivers of both the elderly and the newborns on the on best practices for heat protection is also the key. Finally, we must address the root cause through broader climate change mitigation. This means advocating for implementing strong policies and significantly reduce greenhouse gas emissions through rapid transition into renewable energy and sustainable practices across all sectors. This is the ultimate long term solution. Additionally, fostering stronger interministerial coordination between health and urban development, environment, and disaster management ministries is essential for integrated uh, heat resilience planning that considers all aspects of this complex challenge. So, to conclude, heat waves present a growing significant threat to the health and well being of newborns and elderly in India. Their impact is multifaceted, affecting not only physical health but also cognitive development in children and overall socioeconomic stability of families. Addressing this challenge requires a truly coordinated effort. It is a collective responsibility that demands action from all individuals, families, communities, healthcare providers, and all the levels of government agencies. Looking ahead, continued research is vital to better understand the nuanced impacts. Robust policy implementation is crucial to ensure that plans translate into tangible relief on the ground, and critically, building community resilience, empowering individuals and neighborhoods to adapt and respond is paramount. Only through these concerted efforts can we truly protect the youngest and the most vulnerable among us from the devastating impacts of a warming planet. Thank you.
Thank you very much, Dr. Vanya, for taking us probably into the most important details of understanding the vulnerable population. I think in the interest of time, we're down to 4 minutes left. Can I request if there are any questions from any of our participants? You can please freely raise your hand and unmute yourself if there are any immediate questions, or you can type the same. Um, Gushman, do we have any questions by email or through type through the chat?
Let me check, sir.
Yes. In the meantime, let me quickly put things across in terms of the 4 topics. First and foremost, thank you all to all the speakers. I believe we have had a very comprehensive and holistic approach to the topic as such. And I think looking at the topics, subsequent topics that you will have in the month of June, these are just precursors to probably much more details. But let me start with Dr. Vanya Gupta, where in which he put in a little bit of focus on the newborn and understanding what the exact details are that we need to take as public health personnel, as public health guides to take to the ground in terms of the clear differences that we need to look at, not only in terms of the newborn and its impacts, but also keeping in mind the pregnant woman. And sadly, the aspect of the elderly population is something that gets missed a lot. And I think it's time that more and more conversations and more topics start bringing this aspect out, because we also need to keep in mind the changing demographics of India. So we need to be prepared for things like this. The long-term consequences, thank you for raising those issues out. It also, what you brought about an important point was the impact on comorbidities, especially in the elderly. Something again, once again, which we tend to forget. So for my colleagues listening in, these are points that we have to take up in terms of this topic. How do we enact or take this information and turn it into action? Prevention and mitigation. We ourselves looking at a situation where the government of India, where we are looking at data that shows that things are not too bad this year. But I think she right, as Dr. Vanya probably put it correctly, is we should not become complacent in this. So going backwards to Dr. Karthik, thank you. In addition to some of these aspects, I think one important aspect that he brought about was the epidemiological information. And without getting into too much detail, but also from personal experience, wherein which even in AEFI, adverse event following immunization causality assessment, this was many years ago, where this entire aspect of a newborn child, so linking both the topics, the last topic and what Dr. Karthik mentioned, was when the AEFI causality assessment was being conducted, there was absolutely nothing that could point out to any medical reason as to why the child died. And it was quite confusing, because it was immediately post immunization. But it was in a case of Andhra Pradesh. So looking at the environmental factors, we identified that it was in Andhra Pradesh. It was during the peak heat season, and then it was finally decided to be heat stroke. So just an example point of understanding the epidemiological information, both for us as public health people, when we look back at understanding what has happened, when you're looking at the data, but also as clinicians. And this is where our clinical colleagues are the ones that we also need to ensure that we bring them in whenever we are talking about heat stroke and heat impact in any of our IEC materials. Dr. Harjot Kaur, again, once again, the absolute basics of what's really happening on the ground, probably lessons to be taken in other states, lessons to be taken at various districts levels, to encourage and get more of this happening across the country, especially at the right times. I think one of the things is preparedness is what the overall umbrella is, and the overall focus of what we are doing here at Sphere India Academy. And last but not the least was Dr. Purvi, focusing so much on multi-sectoral aspects, but also some of the points which I believe were very important was surveillance. We sometimes tend to forget the importance of surveillance. We always looked, rightly as Dr. Purvi mentioned, that surveillance is something more in communicable diseases. That's something we understand. But to see it in non-communicable diseases and its impact in terms of utilizing the data, both for administration, for planning, but also for action. I think overall, we've had a brilliant panel. Thank you, each and every one of you, for joining us. My apologies, we've gone 1 minute over the time, but back to you, Gursiman, if there's anything more that you'd like to add, or for any of our senior participants, if there's anything that needs to be added, over to you all.
Yes, thank you so much, sir, and thank you for joining the today's session. And a big thank to our speaker for their sharing their insight. And thank you the moderator, like sir, and leading the discussion so well. And finally, thanks to all participants for the times and interest. And we will have more webinar on this topic and many other related topics also. If you have any suggestion, feedback, or questions, please feel free to write to us, and stay tuned our social media channel and for regular update from Spare India Academy. Stay safe and take care, and thank you so much. Thank you so much.
Thank you. Thank you all for attending.
Thank you.
बहुत बहुत धन्यवाद।